full lecture day to get them pulled right back up to where you guys are at. So we're going to go through tubular reabsorption and secretion and stop there today, and see how close that takes us to the end. Should be fairly close, but we probably won't use all of class time today. So just to recap, where we left off, we were talking about the steps in urine formation. We talked about glomerular filtration and spent quite a bit of time there. And then we started tubular reabsorption, but we're not quite done. And then we'll also tackle tubular secretion. So tubular reabsorption is the process of pulling the filtrate, the materials that we just filtered out of the blood, and returning a large portion of that right back to the bloodstream. And then we'll get to secretion in just a moment, which is essentially the opposite. We established this principle of sodium secondary active transport as being key to the process. So we defined in general what sodium secondary active transport looked like, and that's where we pump sodium into an environment, into a location, to create a concentration of sodium that we can then use to pull in other molecules. And just to sketch that out real quickly, this represents the proximal convoluted tubule, and this represents some cell of the proximal convoluted tubule. And this represents the blood vessel that we're trying to get molecules back into, let's say like glucose. Right? We said that eventually we're going to deplete the amount of glucose in here relative to the blood vessel, and so diffusion won't work. And so one way that we can still get that glucose is use a sodium potassium pump, and to pump a lot of sodium, very, very high concentrations of sodium into that proximal convoluted tubule. And then we can essentially open a door that allows that sodium and the glucose to come in together, and then we can continue to transport that glucose into the bloodstream. So that was secondary active transport. Secondary because this process of absorbing sodium and glucose is passive, but I had to pump the sodium out there, which was active. So it was secondarily active to the passive process. We use glucose as an example, but we can do this with all kinds of solutes that are inside that environment that we want to pull in. We just pump sodium and then make sodium go and find calcium, or make sodium go and find, you name it, some other electrolyte or solute that we want, and we can pull the two in together. Questions on secondary active transport as it relates to sodium? Okay, on this slide, I always seem to turn these in the opposite direction of how they draw theirs. I don't know what that means about me. If I always thinking horizontally, and they seem to always be thinking vertically, but it's the same drawing here, right? This is a cell of the proximal convoluted tubule. Here's the blood vessel. They've just turned everything on its side. Solvent drag is a concept that was just briefly mentioned, I'm not sure, right here, and I said we would come back to it. So let's discuss that one real quickly. Solvent drag is a part of the paracellular route. And if you recall, we said that in order to get materials from our proximal convoluted tubule reabsorbed into the bloodstream, we have one option of going through a cell, or we can go between the cells. So that's all the paracellular means. It means going between the cells during the reabsorption phase. One of the most abundant molecules that's going to be moving is water itself. So we have just pulled out a tremendous amount of water from the glomerular capillaries, and now a lot of that water simply wants to return right back to the bloodstream. So a good amount of the water will just flow between the cells, right? So the cells are kind of working hard to grab the solutes, but a lot of the water will just flow through the spaces between the cells, through that paracellular route. And when water flows, just think of a fast-flowing river, it carries things with it. And so a lot of our electrolytes will be drugged into the bloodstream by simply being pulled along with the water that's flowing between the cells. So that is what is meant by solvent drag. As the water is pulled through, many, and you can just kind of summarize this as electrolytes, even though there are a couple of nitrogenous wastes there, urea and uric acid, many of the electrolytes that we're trying to pull back into the bloodstream are simply pulled in through that movement of water through the paracellular route. There's a lot going on in that slide in terms of protein structures, but for this particular point and concept right now, I just pulled the picture up because it just, I don't know, it's got some arrows on there showing solvent drag. Questions on what solvent drag is? Okay, so again, the blood vessel down here is called a paratubular capillary. It was the afferent blood vessel when it went in. It was the glomerular capillary while it was in there. It was the efferent arterial when it came out. But now when it comes back around by the proximal convoluted tubule, and in fact elsewhere as well, around the loop of Henle, we call it a paratubular capillary. And as we're discussing right now, its primary job is to reabsorb solutes, electrolytes, and water itself. We now know that a lot of the reabsorption comes through solvent drag, and a lot of it is just a consequence of osmosis as well. Water will be attracted to these, remember we said that those proteins that were left in the bloodstream, well, water was attracted to them back here, right? We said that that contributed to the colloid osmotic pressure, right? But we didn't let water go back to them there. Well, those proteins are still here, and water is still attracted to them, so we still get some osmosis occurring here as well. So we get solvent drag, we get osmosis, we get a lot of movement back into that paratubular capillary. There are three major variables that promote the ability of this blood vessel to reabsorb water and therefore also gain access to those solutes that are within the fluid environment of the proximal convoluted tubule. So we're going to look at three things that increase the ease at which we have movement from this location into this location. Number one, we have high interstitial fluid pressure due to the accumulation of reabsorbed fluid in the extracellular space. Let's break that down. Interstitial. Interstitial is the space between tissues. Right? So I've got a tissue here. I've got my proximal convoluted tubule, that's a structure. I have my blood vessel, that's a structure made out of tissues. But in between, this area right here, that is the interstitial space. And that's the interstitial space. It's the space between my proximal convoluted tubule and my blood vessel. So what we're saying here is that as we pull things out of the proximal convoluted tubule and move them into this environment, this space between, the pressure within that space goes up. And anytime we take stuff and put it into a space and pack it full, the pressure inside that space will go up. So my interstitial pressure is going up. If I have high pressure here, it makes it easier to move things in there. So I have a higher pressure outside the blood vessel, which if you think about it is exactly opposite of everything we've described so far as it relates to filtration, right? When we described filtration, we basically said in order for filtration to work, when we get to a blood capillary, I need higher blood pressure in this tube than the surrounding pressure, and then things will escape. Here, I now have just the opposite. I have high pressure outside the blood vessel, so now it makes it easier for things to go into the blood vessel. So that's the first thing. We need to know that the process of reabsorbing water and other solutes is made easier because I have high interstitial pressure outside the blood vessel. Questions there? The second one is, I have lower than normal blood pressure in this blood vessel. Right, we just pulled everything out of it. We just pulled all the water, not all, but we pulled almost everything out of this blood vessel. So it's got really low pressure. So I have really high pressure in the interstitial fluid, and now within this blood vessel, because I just pulled a whole bunch of water and solutes out of it, it has really low pressure, and so now it's made even easier. It has lower than normal blood pressure inside that artery. So now those two things really work in my favor. If I'm trying to put stuff in a blood vessel, it's made a lot easier if that blood vessel has really low pressure. And then also, if the surrounding environment has really high pressure, now double dose of exactly what we need. So those two things, simply having the higher blood pressure outside and a lower pressure inside, makes for easier movement into that blood vessel. And then the third thing are those proteins that we just mentioned. I have a high concentration of proteins inside this blood vessel, and water is very much attracted to them through the process of osmosis. So now I have that colloid osmotic pressure. I have the attraction of water still. It didn't go away. It was present back here. Water wanted to go to those proteins here, but we didn't let it. Now as we get back here, we're going to let water go to where those proteins are. So collectively, those three things encourage rapid, very rapid reabsorption of much of the water that we actually just pulled out of the cardiovascular system. Questions on those three variables or factors that contribute to the ease at which we're moving molecules and water into the capillary? Okay. All right, transport maximum. Go over here. That one's getting kind of messy. So this is still the proximal convoluted tubule. Let's put some cells along here. Little cubes represent cells, and we need the peritubular capillary. So let's say that we are trying to absorb glucose. And so my little red dots represent potential glucose molecules that I'm going to try to put back into the bloodstream. There are limiting factors to how much glucose I can pull out of the proximal convoluted tubule. And those limiting factors are very simply the number of transport proteins that I have on the surface of these cells. So for any particular solute, and we're just using glucose as an example, what will limit my ability to reclaim, to reabsorb those molecules is the number of proteins that can actively grab them and then transport them into the bloodstream. So the transport maximum is exactly that. It's the maximum amount of any particular solute that the proximal convoluted tubule is capable of reabsorbing. So if at any particular point in time, all of my transporters, which means the proteins, right, on the surface of the cells, if every one of those guys is actively working to transport glucose, then the glucose out here might go on by. In fact, by definition, it would go on by. We would miss the opportunity to collect some of those solutes if all of my transport proteins are actively putting those molecules back into the bloodstream. Now, sometimes this is by design, so to speak. In other words, for any particular, glucose is kind of a bad example, calcium might be a better one. At any particular time, there's an amount of calcium that the proximal convoluted tubule kind of knows, okay, this is the amount that we need. And so if we hit transport maximum with respect to calcium, it's okay because it knows, well, I have just the right amount of transport proteins, and therefore I'm getting exactly the amount of calcium I want back, and anything that remains just goes to urinary waste. So it's not necessarily a bad thing to hit transport transport maximum. It's just kind of regulating, or not regulating, but maybe matching the number of proteins on the surface of those cells to the number of molecules that we want to bring in. This can be adjusted to some degree because proteins on the surface of a cell are not necessarily permanent. If we determine, hey, I need more calcium, maybe I add more calcium transporters. Or maybe if I need less, I take some away. So the transport maximum isn't necessarily a fixed value. It can change based on how many of those transport proteins are installed at the surface of the cell. Questions there on the concept of transport maximum? Okay, let's look at a case. Oops, jump past that picture. Nope. Thought I had a better picture. I do not. So this is, again, they're thinking vertical still. It's horizontal in my mind. So it's a very rudimentary drawing here. They've got more of the capillary up there. In yellow is their proximal convoluted tubule, and they're showing glucose transport proteins. There's just these little blue dots, and I guess the green is supposed to represent glucose. And on the left, they're showing you, hey, this is what ordinarily ought to happen with glucose. We should have a matched amount of transport proteins compared to the amount of glucose that we just filtered out. So in essence, we essentially we transport nearly all of the glucose back into the bloodstream. So glucose molecules that are here will find themselves with a sufficient number of transport proteins to get that glucose back into the bloodstream. When we have excess glucose, hyperglycemic conditions, right? We have too much glucose in the bloodstream. Obviously, this could be a result of type 1 or even more likely type 2 diabetes. So if we have too much glucose in the bloodstream, then we're going to have glucose traveling through this proximal convoluted tubule that cannot be captured by a protein because that protein is already working with a glucose molecule. So we're going to start missing some glucose molecules. And those glucose molecules will have nowhere to go but end up in the urine. So under normal conditions, we do not urinate anything even remotely close to a significant amount of glucose. But under hyperglycemic conditions, we do begin to urinate glucose out, simply because the transport proteins are missing. And it is a good thing, really, that they are. It is a good thing that they're missing that glucose, because if we return that glucose to the bloodstream, that would be problematic. We would be even more hyperglycemic than we already are. So it's not like it's a purposeful action to urinate out excess urine, but it is a result, and that does help lower the blood glucose levels of somebody that is hyperglycemic. Now, this isn't an answer, a permanent answer to the problem, because when you have excess amounts of glucose ending up in your urine, well, water is attracted to glucose. And so later on down the line, we'll see, especially with the collecting duct and with the DCT, we'll actually start having water attracted to that glucose, and we'll end up creating states of dehydration as water leaves with the urine. So we'll have increased urine load and high amounts of glucose in it. I'll probably circle back to that towards the end of the unit as we talk a little bit about a little bit more detail on the relationship between type 2 diabetes specifically and the urinary system. Okay, so transport maximum is simply the maximum amount of solute that we can absorb, and sometimes we hit saturation point where we're transporting as much as we can, and anything that we can't capture will end up in the urine. Questions? Okay, so that's everything, at least for now. We're going to come back to, I think I left you guys last time talking about how we will revisit. Way back here. hormonal control. Right? We didn't talk about any of the hormones yet, have we? No. Okay. So we will revisit tubular reabsorption when we come back to hormonal control. We'll do that next Monday. But for now, we're ready to go on past tubular reabsorption to tubular secretion. So tubular reabsorption, taking things out of the proximal convoluted tubule and putting it back in that blood vessel. Tubular secretion, just the opposite. There might be things in here that we missed that didn't get filtered out that we want to put back into the proximal convoluted tubule. So tubular secretion. Okay, so let's think about, we've defined it, right? Tubular secretion, again, just the movement of anything back into the proximal convoluted tubule. Really, back into isn't the right way of describing it because it was never in there, but moving molecules from the peritubular capillary into the proximal convoluted tubule. That's simply what tubular secretion is. Let's talk about why we might engage in it. So underneath that second bullet, it tells us at least a few reasons why we might engage in tubular secretion. One primary reason is to control acid-base balance. So the pH of our blood needs to be right around 7.4. And it is one of those really critical tissues that doesn't allow for very much variance when it comes to the pH. That, cerebral spinal fluid, and maybe just a couple of other specific examples, are those tissues that have to maintain a very, very tight, close pH because so much of the chemistry that goes on in our bloodstream depends on that. So how might we help hold the pH of the blood where it needs to be? Well, having really nothing to do with the filtering of metabolic waste, if we discover that the pH of our blood is too high, right? So let's say it's maybe pH 9, that would be lethal, but let's just make it a real high number so it's obvious to us that it's higher. So let's say it's really high pH. How can we lower it? Well, proximal convoluted tubule, that's just going to become waste. Now we have to go back and think about the relationship between pH and hydrogen ions. Okay, so when pH, the actual number, so pH 9, what does that represent for the quantity of hydrogen? Lower or higher amounts? Or? Excellent. They're inversely proportional to each other. Okay, so they're inversely proportional to each other. When pH goes up, it means that in that tissue, the amount of hydrogen went down. Okay, the amount of hydrogen went down. So over here, pH went up. That tells us that the amount of hydrogen in that blood vessel is lower than it ordinarily is. So I want to take not hydrogen ions, I want to take OH negatives and send those to the bloodstream. I know that's not mentioned here, but the opposite way of thinking about it is I want to, oh no it is, sorry. They reference bicarbonate, but essentially we can think of it this way, that the last thing that I want is to reduce that any lower. Right? I want to hold on to my hydrogen ions. So actually, since they didn't mention OH specifically, or I guess let's reverse this. Let's make it even more simple. We'll ignore bicarbonate and carbonic acid and hydroxide ions. Let's just focus on the hydrogen itself, because the relationship is here. So what I want is for this to go up. So I want more hydrogen. So I'll simply secrete less of it, right? So that's what would happen if our pH is on the rise. I'm going to hold on to hydrogen here. The opposite is even easier. If my pH is too low, now that means I have too much. This is the problem that I have. I have too much hydrogen in the bloodstream. So that is when I will actively pump hydrogen ions into the proximal convoluted tubule. I'll just get rid of them to reduce the pH. So if my pH is too high, I want to hold on to hydrogen. If my pH is too low, I want to get rid of it. And there's a route that I can get rid of that excess acidity. Okay. Questions on the acid-base balance in terms of the most need to know as it relates to hydrogen? All right, down below that, it's pretty simple and pretty straightforward. Waste removal. This is just kind of a catch-all for two problems. I mean, not really problems, but anything that is definitely considered a waste that somehow made it through this tube and didn't get filtered out, I now have the opportunity to take that molecule, it was a waste molecule, but it just didn't make its way out through filtration, and it's still here now. I can transport it into the proximal convoluted tube. That's simply what we mean by waste removal. The other, still waste removal, the other issue, I don't know if you caught it, but back here, under solvent drag, notice I've got some nitrogenous waste there. It's pulled back with that water. I don't necessarily want all of that to go, right? Actually, I want a little, but we'll explain that later. But I lose some nitrogenous waste through that solvent drag. So some of the waste that I might be putting back into the proximal convoluted tubule wasn't waste that I missed here. It was waste that was here, and it got drug into the blood vessel, and now we're like, no, you go back. So waste removal is just catching those waste molecules, often nitrogenous waste, that maybe got missed here, or were transported here, but we don't want them there. Now, all of those things, the urea, the bile acids, the ammonia, the creatinine, all of that's just normal metabolic waste, right? It's the stuff that the kidney's used to seeing all the time. Down at the bottom, drugs and contaminants. This is the junk drawer, big catch-all for any number of other things, many other things that's in the bloodstream that we weren't ordinarily equipped to filter out, but now we can transport directly out of the bloodstream. So it's just a catch-all for, hey, there's going to be lots of things that might get into the bloodstream that we didn't filter because the filter wasn't maybe perhaps designed for them, but I still have the opportunity to pump them right out of the bloodstream.
Is that like whenever you take a drug test, they like test your urine? Is that why you come up positive?
Right. So yeah. So many times, not only are we equipped to remove it here, but we don't have mechanisms to remove them all here either. Yeah. Other questions? Okay, well, shoot, I said that we're going to do one more thing, the nephron movement, and then we'll largely shut her down for the day. Short lecture. We'll have a few other things to say about the nephron loop, but its primary function is going to be, I'm going to draw a large kidney here. This is my kidney. And we have already identified the different regions, and we have described these renal pyramids. We've talked about the basic structure of the nephron, which is the glomerular capsule, proximal convoluted tubule, nephron loop, and then distal convoluted tubule. And then that distal convoluted tubule connects to a collecting duct. So let's say that this line is a collecting duct. And now that collecting duct is taking the fluid out of the kidney and will become urine. That technically is once that fluid is inside the collecting duct. We said that in step 4, What we're largely doing is, so let's say this is the collecting duct, and this was the DCT as it entered it. That's just all waste that's headed out of the body now. There's absolutely no way for me now to modify what is in there with the exception of water itself. So I have the ability to control how much water I pull out at that point, but nothing else. I'm not going to pull out any more waste, no more, I'm not going to add anything back to this. I'm just going to modify how concentrated it is. So now we can think about, well, how do we pull water out? And the nephron loop is very important to understanding how we pull water out. What the nephron loop does is it essentially releases or secretes, it's hard to read, NaCl, salt. So this environment, the renal pyramids, they're salty. It's a salty environment. They're salty because, again, that nephron loop is secreting salt into the environment around it, sodium chloride, NaCl. So I've got this salty environment here. Okay. So surrounding, this is the collecting duct, right? I would have a collecting duct going right through that salty environment. So this tube is surrounded by salt. Salt. And water is attracted to salt, right? Through osmosis. So I can now affect the movement of water by adjusting how salty this environment is. If I want more water, more salt out here. If I want less water, less salty environment out here. We'll get into next week a little bit greater detail on how we accomplish that, but right now, for at least this one simple slide, we just need to know that one of the primary functions of that nephron loop, also called the loop of Henle, is to secrete salt into these renal pyramids, making that particular environment of the kidney a salty environment, so that when a tube filled mostly with water passes through it, there will be the opportunity to pull water out of that tube. Salinity, salty, same thing, right? The saline concentration is, for our purposes, synonymous with saying the salt concentration. Saline, salt. Salinity, salty, means the same thing. We'll come back to that as well, but questions on the general function of the nephron loop. Okay, so just to recap before we leave, what we've done now is we have kind of generally described those four steps: filtration, tubular reabsorption, tubular secretion, and we just now kind of touched on water conservation. We'll add a layer of complexity, but not much. Mostly what we're going to do next, and again we'll start this next Monday, is we're going to talk about how specific hormones that your body secretes affect potentially all four of those events. So certain hormones that your body produces might affect tubular secretion, tubular absorption, water conservation, not so much filtration, but certainly 2, 3,